Welcome to welcome to Healthcare Half Hour on a gray morning. Looks like we're going to be having some snow, so might as well just stick around, listen to us for a half hour. We're going to get you woken up and ready to go with your day. Have some coffee ready, because once we start, we're just going to go. This morning, I am thrilled to have with us for a discussion about rapid testing, Laura Murray. She's the area medical director at Cone Health Medical Group. She's a physician. She's an internist whose training is in caring for sick adults. She's worked primarily in hospitals. She also has experience in critical care, and she is now a physician leader at Cone. And our other guest this morning is Tom Denny. He's Tom Denny. He's the Chief Operating Officer for the Duke Human Vaccine Institute. He's a lab scientist, and he started his career doing HIV work. So as he says, this is not his first pandemic, and his work is around developing diagnostics. And in case you don't know, I'm Rose Hoban. I am the editor of North Carolina Health News, and I'm going to be your host this morning. And so let's jump right in. Thanks for joining us, Dr. Murray and Tom. I'll just call you Laura and Tom, just because we want to keep it casual here. And so can one of you, let's just start from the basics, right? Can you folks explain the difference between PCR testing and antigen testing? Someone wants to give us?
I guess I'll take that one. So PCR test is a molecular test, and it's think of it as if you're looking for a needle in a haystack, you're doing a process of amplifying the amount of needles that are in that haystack so you can light it up and see it real easily. It has high sensitivity and high specificity. An antigen test is not a molecular test. We refer to it as an immunologic or immunovirology test. You do not do any amplification of the signal that's present. When I say the signal, I mean the virus that's in the sample that you're trying to detect. And it has a lot of specificity, but its sensitivity is a bit south of where PCR is. And how far south that is depends on a lot of characteristics of the actual time of infection.
So you're saying sensitive, meaning like it can pick up an infection really well, like PCR does that really well, whereas antigen might not be so great at it.
Yeah. So most of the studies within the COVID antigen assays compared to PCR have shown that they're about 10 or 15% less sensitive than PCR is. And then that also is dependent on the time of infection. So antigen assays are generally not that good in what we call the asymptomatic phase or the ramp up to infection. They're pretty good when you're in that symptomatic phase and you have a lot of viremia or virus that's being made. PCR, on the other hand, is very good at picking up the very early on infection and what we refer to as the asymptomatic phase.
Laura, you want to jump in at all and add anything?
Yeah, I think clinically the way we use these tests, a PCR test is so sensitive and it picks up everything. And so I think that sometimes it picks up people who are not particularly infectious right now, right? We know that you can test positive for as long as 90 days after an infection. And it's not particularly helpful once it's long after the infection to know that you were infected. And so that's one of the drawbacks as far as the PCR test goes. I think early in infection, that is the test that you would like to, right? If you knew that somebody was about to get infected, about to be symptomatic, you would love to know that so that you could use the PCR test then. And like with all clinical medicine, it's a little fuzzy, and so some of the other factors that come into play with PCR tests are that the turnaround, because it's a more complex test, it takes a little longer. And so sometimes what we're seeing right now in the test sites using PCR tests is that it takes a couple of days for the test to come back, and you might sort of be over it and not really that infectious anymore by the time you even found out that you had it. And so that's the value. That's why to have antigen tests and why to use them. Now, one of the things that's intriguing about it, the antigen test, the way we try to deploy them is to detect people who are contagious. Right. So that's really when the antigen test performs the best. It tends to be positive when you are pretty contagious. It tends to miss you if you're on your way up, about to be symptomatic and early in infection, and then it drops off fairly quickly later in the infection. So these are the types of tests that typically come back in 15 minutes. And so you get a rapid sense. If they're widely available in the community, people could do a lot of tests and sort of compensate for, you might miss it early on before people have a lot of symptoms and are actually producing a lot of germ that can be detected. That being said, I think there's some differences. We've used antigen tests previously, right? The rapid strep tests are antigen tests, the flu tests are antigen tests. And I think there's a difference in the sensitivity. So frankly, I would love Tom's thoughts on the difference in sensitivity, because I think there's been a wider range of variability for some of the previously used antigen tests. And then here we are with COVID, and a lot of the tests seem to be a lot more sensitive, not 50 to 70% sensitive, but more like 85. And so that seems like a big improvement. But I'd really be interested in your thoughts.
I'm going to ask you to sort of move on, though, because I really want to talk about like COVID testing, and we want to be very
one brief aspect of both testing. Let me just get out there that sample collection is the quality of the sample collection is essential to testing, whichever platform you're using. Number one. Second thing is all tests that we do need to be in the context of the patient and having the physician interpret, because a lot of times you get a test that says one thing and there is clinical symptoms or clinical signs that point in another direction. So it should be used in the context of that.
Absolutely.
So what is, we're hearing some things about the Omicron variant. What's the best data test? Tom, you mentioned this ramp up period. Like when is the best time to test now? Stuff is all over the map, right?
Yeah, so most of us are thinking that, Omicron is so infectious and its ramp up period is very short, a couple days, probably 48 hours to 72 hours, compared to Delta that was 5 to 7 days. So if you have had an exposure, significant exposure, then testing 24, 48 hours after that is your first time point would be a good time to do it. And again, it depends on which test. If you're using the PCR test, you could try 24 hours. If you're using an antigen test, I'd probably wait 48 hours minimum. And then the other part is if you have any symptoms, obviously, then you test. But if you're in that sort of watch period, 48 hours would be a good time to, I think, have your first test.
Right. Look, I'm hearing even longer that for the antigen tests, it might be taking 3 to 4 days.
Yeah, it varies. We don't have a lot of good information. Again, you have to be careful. Omicron's only been with us about a month and a half, 2 months maybe, and we're learning. So it depends on testing resources. If you have limited testing resources and you're only going to get one shot at it, then maybe wait a few days extra. If you have enough testing resources and you can do multiple tests, then obviously the earlier you identify someone that they can be in isolation or try to prevent transmission is a good thing. So it's a combination of factors that one has to balance.
Mm-hmm.
Go ahead, Laura. Maybe just keeping in mind that if you were face to face for a significant amount of time with somebody who turned up positive, and you do a test in a couple of days and it's negative, just take that with a grain of salt. I think that the key message here is that just being aware that we'd all love to get a negative, and that's the end of the story. And if you're face to face with somebody who's positive, a negative, especially a negative rapid test, maybe just continue to exercise caution.
All
When you
testing is a
say,
snapshot. All testing is just a snapshot in time, and you have to keep it in that perspective.
when you say a significant amount of time, Laura, what's significant? Is that 2 minutes, 5 minutes, an hour? What is that? Do we have an idea?
For me, if I'm face to face with somebody and there's for 2 minutes and there's a significant cough, right? And I'm right there breathing the air because we're drinking coffee and giggling or whatever. I'm going to, even though that's not a 15 minutes in 24 hours kind of an exposure, I'm going to say that was a big germ load that somebody, right? If you're coughing or sneezing or blowing your nose, you are putting a lot out at force. And so you might weigh that differently. I think we sort of routinely recommend 15 minutes exposure in a 24-hour period, closer than 6 feet, yada, yada. And if somebody is coughing or sneezing or blowing their nose and I'm right there, that's for me. That, they tell me a couple of days later that they were positive. That's really, I'm going to go get a test. I'm going to wait a couple of days. I'm going to get a test.
Mm-hmm. I'm going to do a quick station break here and remind folks that you're watching Healthcare Half Hour. Get yourself some coffee. And then when we're all done, you can surf on over to www.northcarolinahealthnews.org to sign up for our newsletter. And that way you'll be informed about everything that's going on, everything we're publishing, and events like this. And also while you're there, we'd really love it if you made a donation. We are a not-for-profit and we are dependent on your generosity. So let me going back to questions here. I'm hearing about like these people who are having symptoms before they're testing positive on an antigen test. I'll do the basic, but like, what's up with that, right? I thought you were supposed to be able to detect COVID once you became sick.
Well, again, keep in mind what I said a few minutes ago. Sample quality is also a factor in this. So, you could have 2 excellent tests, PCR and antigen, but if you fail to get a good quality swab, you may have inaccurate results on either one of them. So, when we talk about testing, we have to talk about the whole process. And a lot of times we focus on, the antigen strip versus the PCR. But there's a lot that has to do with how you get that sample collected and the quality of it that goes into the test. In the lab, we have a phrase that we refer to garbage in as garbage out. So if you get a bad sample coming in, you're going to get a bad result coming out. So you have to balance all that and be aware of that. So if you have someone that has symptoms and you're getting some negative tests, you should go back and repeat that. And having said that, I will tell you, from 2 years we've done over 1 million tests probably in our asymptomatic program that we do. There are a rare number of people that are positive that do not shed virus. Mm-hmm. If you look at them 3 or 4 weeks out, you'll find that they had antibody and that they had an infection. But during the acute period, you will not get a PCR positive test. It's a rare number, but it can help. That's where I said it has to be the testing result in the context with the physician and the care of the individual. That has to be balanced.
Absolutely.
And the symptoms. And Laura, how far should the swab go in?
Well, the swab, the tip of the swab is, half an inch or an inch long, and the whole swab should go into your nose. And so I think one of the things that's been interesting for me is the number of people who are squicked out about putting something into their nose. I mean, I certainly have, as a clinician, encountered lots of people who didn't want a throat swab, but I never really thought of the nose as a place that people would be so uncomfortable about. But you really do have to put the whole tip of the swab in the nose. You have to press firmly against the sidewall and go around. And it's uncomfortable. It's not a brain biopsy. It shouldn't bring tears, but it isn't comfortable. And so I do think that there's that. Be sure that you're doing a vigorous test, and also there might be an impact if you've just blown your nose, right? There might be an impact of if you have really humid air in your house and your nose is dry. So I think because we're trying to detect a little bit of mucus in your nose, right? And so these are all things that could impact the sufficiency of sample. So it's not rocket science, but it's, there's some technical factors.
Well, part of me feels like, consult your local 5-year-old, right? Because, instead of this, we're like this, right? Because kids know how to get up
the whole
there.
Tip in there. Yep. Press firmly.
So, So Leah Lanninger, and this was going to actually be my next question too. She said, she asked, what's the current thinking about swabbing the throat as well as the nose with a home test? We're hearing a lot about like samples, sample quality, pH levels in throats, like, is Omicron more in the oropharynx rather than the nasopharynx? Like, can you help us out here? What do we know?
So from a testing perspective, one should not change any sample acquisition that the test platform was approved under, like the EUA criteria, unless there is a side-by-side study that's shown that says an alternative sample is as sensitive and specific as the one that was approved. So what do I mean about that? We're hearing these anecdotals that you referenced, the throat swabs. There has not been a side-by-side study that said if I take 30 people that are positive and take a throat swab, and those same 30 people, I take a nasal swab and I compare the results, am I spot on and in agreement in all cases? So you do not want to change your clinical practice based on these anecdotal stories. Now, having said that, we are looking, a number of us are trying to set up studies where we do just that to show, is there any difference? And it could very well be that a throat swab is more sensitive with this particular variant. But you wouldn't switch a medication unless you did a side-by-side trial, and you should not switch a testing platform process.
There's this data out of San Francisco that a lot of people are looking at. Laura, like, I'm sure you've seen that preprint. Like, thoughts on that? I mean,
so one of the things for me is how much of the transmission of this variant would need to occur salivary wise for us to manage and try to detect it differently, because the contagiousness of Omicron argues against, for me, that predominant transmission is actually a salivary method. I am sure that there is germ in saliva. I don't know if that's a better way to detect it or not. I know that when we look at contagiousness of strep throat, that transmission is it's air, there are respiratory droplets in play, but it's not contagious in the way flu and colds are. And so I just have to believe, given the numbers that we're seeing, that COVID is still predominantly being transmitted in a respiratory droplet or airborne fashion. There may be some role for saliva, but right now I just don't think I just can't at the gut of it believe that that's a better way to try and detect it, because what we're seeing is frankly so consistent with airborne or respiratory droplet transmission.
Got it. Are all the tests are they equally reliable? There's like Binax, there's like a whole slew of them on the market. What do we know? Like, is there one that we should really be looking for?
My view is, if it has first off, you don't want to be doing anything that's not an EUA approved testing. And having said that, again, we really have not had the ability. We're so much in a war with trying to stay with the current that, normally what you would do, and eventually this will be done, is you'll take 3 or 4 of these tests and you'll do side-by-sides. And it may very well be at the end of the day that each one, there's a little bit difference in some sensitivity or specificity. But I think at the end of the day, they're all going to be probably equivalent for what we want to use it for. The ideal testing scenario would be use a PCR test on the early part of infection, that ramp up period, and then use an antigen assay, a strip test, to be able to pick up someone to see if they're truly infectious or not infectious, and then clear them as fast as possible. We're not going to be in that world, but that would be
that's an ideal world, right? That's an ideal world. Yeah, because it's just so there's just so much disease out there, right? Like your lab, Tom, would be completely overwhelmed if everybody got it.
You're absolutely right. We can barely stay afloat with what we're doing now.
Right. And folks know that they can sign up at covidtests.gov. I've already signed mine up. I'm timing. I signed up on Tuesday and I started my clock to see how fast those are coming. So
they really come in 7 to 10 days.
Do we know what tests they're going to be sending out, or is it just kind of whatever they've got in the warehouse they're going to ship?
I have no idea.
I did see that, well, what their ship, so the federal government has employed the Defense Production Act for this, and they did make contracts to 2 companies, I believe. I'm forgetting the names of them. It was not the Abbott Binex, as I recall. It was another company. And again, the ramp up in production of this takes time. It's not going to happen overnight.
Got it. So, okay, I've been exposed. I was chatting with someone, we were, drinking coffee. I thought it was all good. They went, and then we were laughing. And then they called me the next day. They're like, oh yeah, I'm really sorry to let you know. So, I can't shut down my life, right? Like kids going to school and whatnot. How do I mitigate my risk? What this gets into that flow chart that you folks helped me to develop, and that we based it on the CDC. What do I do now? How do we mitigate that risk?
Well, I think right out of the chute, the best protection sort of preemptively is probably a vaccine, because that we know that there's good protection as far as limiting how sick you might get, right? Keep you out of the hospital, potentially keep you from dying of COVID. We know that that's a helpful. And along with that, if you get the virus, and it hijacks your machinery to make more copies of itself, which is basically what an infection is, you are so much less contagious. You are making less germ. If you are
if you're vaccinated.
Yes, if you are vaccinated and you get COVID, you are less likely to get very sick yourself, and also you are less of a threat to others. And so that's really valuable. So that's why we're pushing vaccines, because they work. And so then the second piece of that is, so getting a vaccine, being ready, and then wear a mask. Keep a little back from people, right? Wear a well-fitting mask, and don't be face to face with people, right? And if people are coughing or blowing their nose or sneezing, back up, right? Get out of that air. Don't expose yourself to that. And so I don't think that means that you have to stay home all the time, but exercise due caution. We had gotten kind of sloppy about respiratory protections. We didn't routinely say to ourselves, oh, that person is coughing. Maybe I don't want to be right next to him, right? I mean, that's the kind of thing we have not done well as a society. And these are things you can do.
You talk to that person, you can see like spit coming out of their mouth, right?
Looking at the same, I agree 100% with the social distancing, masking, and vaccination. But you look at another indicator. Look at our flu rates. Our flu rates are low.
It's wonderful.
And that's a indication of success with masking, with social distancing, with using some common sense about the prevention techniques.
Yes.
So this looks so flimsy. I mean, it doesn't really work. I mean, we haven't heard huh?
It's multi-layer. Yeah. It's the multi-layer, multi-layer works. And, keep in mind, surgical masks have been used in operating rooms for years and have been a good tool.
And we wouldn't be operating without them, right? Because they work.
Obviously, if you can get a tight fitting N95 mask, sure. But don't let the perfect be the enemy of good, or whatever that version is. I get it, but yeah, take what you can get, and if you have to improvise a bit, it was better than nothing.
Yes.
Well, I hope we just answered Annie Dance's question about wearing masks. So we haven't heard as much. I mean, Mandy Cohen's gone. She was the 3 W's lady, wear a mask, wear a mask, wear a mask, right? So, but this is. Right.
Maybe I'll get myself in trouble now, but the thing we've done wrong with this disease is we made it political, and we've not allowed it to be a public health challenge. And if you follow the true public health, masking clearly makes sense. It clearly makes sense. You go back to TB things in the 20s and 30s, masking works.
Mm-hmm. So actually, let me do another station break. Want to remind folks that they're with North Carolina Health News for our monthly healthcare half hour. As you can tell, it's a quick moving conversation. And you can sign up for our newsletter so you can be abreast of all of the news and get word of these types of events at www.northcarolinahealthnews.org. You can even type in nchealthnews.org. And to remind folks, we are a not-for-profit and we depend on your donations. And so we really would appreciate it if you helped us out. So anyway, what about healthcare workers? You both work in healthcare institutions. There's these guidelines now about like healthcare workers who we know that 99.9, I guess they're all, vaccinated at this point and boosted for the most part. So what happens now? Like they get tested with COVID. When can they go back to work? Like,
well, I think that one of the things to keep in mind, there might be a difference in recommendations for healthcare workers versus the general population, because when healthcare workers come to work, they're wearing a mask. There's very strict attention to detail wearing a mask, right? You will be wearing a mask at work. You will not be breathing on people. You will not be breathing on each other. You will not be breathing on patients. And so that is a level of protection that's not something we see out in the general public right now. The mask mandates in public have mostly gone away. It's kind of on you to remember and exercise caution and be back from people and be wearing a mask, to protect yourself and if you to protect others. So in healthcare, we're wearing masks, and so that for me is the explanation about why there might be a difference in recommendations, because it's a protected setting.
Yeah, I agree. I agree. And again, in an ideal world, you'd hope you had the resources for more testing. But we have to acknowledge is, as a country, we've failed with testing as a tool from the beginning of this pandemic, and we're still playing catch up. So
it's still failing.
Yeah. So if you had adequate resources in testing, then you could deploy it more frequently in a lot of different settings, school settings, wherever you
absolutely,
wherever you want to workplaces. But so we have the balanced resources that we have.
Can someone explain sort of like quarantine versus isolation, and what's the difference, and talk a little bit about the CDC guidance around them?
I'm glad to take a shot.
Go for it.
The isolation is if you're infected, you got a positive test and you got to stay away from people. Quarantine is when you've been exposed, and then you need to stay away from people, because we don't know for sure yet if you're going to be infected or not, and so you need to exercise caution. You have a little more leeway if you've been fully vaccinated and boosted, according to the CDC, as far as what level of protection is it? Really stay home and close the door, or is it wear a mask and keep back from people? And so there's a little bit of difference in the recommendations for quarantine for people who have been vaccinated and boosted, or not completely vaccinated and boosted. As far as if you have a positive test, you should isolate, and that's home for 5 days, and then if all symptoms are gone, and that's
I think that semantic difference is confusing to folks, because you would hear like, oh, he's in quarantine, right? So that tended to mean, I think the newer CDC guidance says stay home, right?
That's what we mean, right? Isolate, quarantine, it's the same difference.
These are scientific terms that have been around for years, and it really, like Laura said, one is a watch, and one is a watch period, and one is it's been defined. The outcome there. So, from a counting perspective, for statistics and following, it's important to know that how many people are you quarantining, how many people you have in isolation. It matters with something, but at the end of the day, it's the same concept.
We have a question about, an algorithm related to exposure. So if you check out the story that we published on Tuesday, as I was saying to Laura when I was working on the story, I'm a visual learner, and there's been a lot of talk and there's been a lot of stuff printed. And so I decided to just sit down. They're kind of rough, but I just drew myself out a flow chart, because that, that helped me to sort of picture like, oh, this is what to do. And here, how did I do on the flow chart, folks? Laura and Tom?
I thought it was helpful.
I thought it was very helpful. And again, for even people in the health field, sometimes it can be complicated navigating the choices. And again, given that it changes, or has changed fairly frequently. But again, some people criticize that. Keep in mind again, we're learning information all the time, and as we learn new information, it does make sense to update what you're doing. And that's where we're taking data, we're taking information, and we're making adjustments to what we do.
Let me ask you a question. Why is the US so behind on rapid testing? Like they've got them in Europe. One of our interns from last summer is studying in Spain this semester. And she was like, I can walk in any pharmacy and I can get them super easy. Like, why has it been so hard here?
I think our comfort. Go ahead, Tom.
Yeah, my view is we just totally miscalculated on this. And now we did some wonderful things with the discovery and rolling out vaccines in an incredibly short period of time. We got that so right? And I think what happened was when all that started to roll, the thoughts were, oh, we're not going to need that much testing. So we don't need to keep the foot on the throttle and do things for testing. And that's proven wrong. And I think what you're seeing now is catch up. We don't know where we're going. Is there going to be another variant that is more challenging or less challenging? But the prudent thing to do now is to make sure we get the testing resources at a high level to be able to support whatever we're faced with. We can ramp it down easily in the future, but right now, we know we have 35 or 40 million people that are not vaccinated. And that means there's a lot of potential transmission and a lot of needs for testing.
Yeah. Omicron is so infectious. When we were talking, we did our practice on Tuesday, we all were talking about the fact that we got really lucky that Omicron happened now and that Omicron wasn't the original because we would have been screwed, right?
And we got lucky that Omicron appears from a pathogenicity standpoint to be milder than the earlier versions. If we had the earlier versions, level of infectivity, it could have been game over big time.
So on that, somebody asks here that they're seeing by the way, it's 9:04. Can you folks stick around for like 2 or 3 minutes more?
Sure.
Okay, great. Thank you. So someone asks here, Queen Smalls asks that has a few friends and acquaintances where symptoms are varied who are vaccinated and boosted. Is the vaccine reliable for like Omicron and new variants?
Yeah, I think the data has shown that for all the vaccines that we have right now for COVID, they do not prevent infection.
Correct.
But if you get infected, if you look at your ICUs, majority of the patients that are in an ICU and on a ventilator are not the ones that are vaccinated. They are unvaccinated people. So the important message to take home is that if you've been fully vaccinated and boosted, most likely you are not going to have significant adverse course of the infection. Now, having said all that, we want to improve upon the generation of vaccines, and many of us are working on that. And if you go back and you look at childhood diseases and the vaccines that were developed, they were developed and refined over a number of years. We're all, it seems like it's been an eternity, but we're only 2 years into this, and to have gotten a vaccine, I've worked in the HIV field for 35 years, and we're still searching to prevent a vaccine.
Yes.
We got a number of tools in the toolbox in a very short period of time for vaccines with COVID. So we will improve it. It'll take some time yet. Eventually, you may have a combined flu and COVID vaccine.
Exactly.
Looking 5 years out, but but what we have now does work.
Yeah, it is power protection. That's
it. Yeah, so it's and it's not gonna Laura, you're saying like all these people in ICUs and on ventilators are primarily unvaccinated. Like, what's that proportion? Is it like 90% are unvaccinated, 95%? And what are you hearing from those patients?
I think it's 85 or 90%. And sometimes they're angry, right? Because they really believe that they were not going to get this sick, and so there's a lot of anger that can come out. It's just an unfortunate circumstance, and I think a lot of times they're just glad to be where somebody can try and take care of them.
Mhm. How long after you've had COVID can you get a booster? That was one of the questions that got asked.
I think there are variations between the vaccine types about what the recommended timeline might be, but you know, I think that in general, 6 months is a reasonable benchmark. What do you think, Tom?
Yeah, and I think some of us may even say a little bit shorter. The original guidelines in the early days of say waiting 6 months, the reason for that was we had limited vaccine availability.
True.
And the thoughts were, if you had COVID, you had some antibody protection.
That's right. We did have people wait for 90 days or longer.
So we let that group wait a bit while we could get the people that had never experienced infection vaccinated and sort of triage the use. I think today that we're given the availability of the vaccines, we're willing to compress that a bit, and we don't see any, you know, adverse reasons why not to give it sooner.
Yeah.
And what we do know is, and clearly for the data, and we don't have time here, but the data has shown very well that if you were boosted,
Yes.
the third shot, you have a very high coverage against Omicron at about 2 weeks after that third shot. And now the question long-term will be, what's the durability of that? Does it last 6 months, 9 months, a year, or, you know, do we have to think about other boostings?
Right. So we've got 2 minutes and then I'm going to cut us off at 9:10, let everybody get on with their day. But what do you see coming down the pike in terms of rapid testing? What Tom, you know, pull out your crystal balls. Tell us what you think is going to happen.
There are a lot of companies are working on developing some innovative technologies to make it simpler, make it a bit easier process. I think we'll see them. I think it's still going to take some time. You know, you're still going to want to see testing at some level, I think, for schools until we get young children vaccinated. I think you're going to want to see testing at some level to go to large events, you know, basketball games, you know, concerts, things like that. So to have a technology that's simple and quick and accurate is that need is not going to go away in the short term.
Laura, any thoughts as we look into the future?
No, I would just second that. I think there's a lot of machinery working to make tests that available, that we can do that the tests would be that fast, that easy to use, and that available, that expectation could be reasonable, that we would have testing in the schools on a frequency and testing before events on a frequency, and that it's just that easy.
And Tom, I'm guessing you know Bob Califf because he came from Duke. So, you know, you need to sort of tell our next FDA commissioner to get a move on.
We talk frequently, and I'm eagerly looking to Bob being the next FDA commissioner, and hopefully within a few weeks they'll see that vote and he'll be confirmed. But he's a great guy, a lot of talent and experience.
Let's get it moved on. Let's get the rapid test moved on. So, well, thank you both, Laura Murray from Cone Health and Tom Denny from the Duke Human Vaccine Institute. I really appreciate you taking 40 minutes. It was a healthcare 40 minutes this morning. And I just want to remind folks that you've been tuned into Healthcare Half Hour from North Carolina Health News. You can find us on the web at nchealthnews.org. We published a story on Tuesday about rapid testing with my hand-drawn algorithms for you to follow. And when you're over at our website, you know, we'd really appreciate it if you made a donation. I'm going to sign off, but thank you very much, and have a great day, and stay safe out there, both from the virus and in the snow. So thanks, folks.
Thanks so much for having us.
Thank you. Enjoyed it.